Hello everybody. Today's topic of discussion in this audiobook session is neonatal resuscitation. In newborn babies, the priority is given to respiration followed by temperature and circulation. In the initial assessment, few questions are asked like what is the gestational age of the baby, is term or preterm. Next, whether the baby cried after birth, the amniotic fluid status, whether it's clear or meconium stained, any additional risk factors, the umbilical cord status, whether there is any delayed cord clumping, whether any investigations done from umbilical cord, etc. If the baby did not cry during birth or after birth, then we have to go for initial steps where we need to maintain the temperature of the baby by putting the baby into a warmer. And we will stimulate the baby by gentle tactile stimulation by rubbing the back of the baby or flicking the soles of the baby. Then we need to position the airway of the baby by slight extension or in a snipping posture by placing a rolled cotton towel behind the shoulder blades. Remember, hyperextension or flexion of the knee is not done. Just slight extension is sufficient, that is sniffing posture. Sometimes suctioning of the secretions to prevent aspiration could be done, and this is not a compulsory step, it is an optional step where suctioning of the mouth is done followed by nose to prevent the aspiration. If the baby still does not cry after these initial steps, then we have to assess the heart rate and respiratory effort. Remember, the normal heart rate is 120 to 160 per minute. If the heart rate is more than 100, but the patient is having inadequate breathing or labored breathing, in that case, oxygen supplementation by oxygen hood or nasal prongs are sufficient. If it's a preterm baby, then we can go for CPAP, continuous positive airway pressure. But if on assessment of the heart rate you find heart rate is less than 100 or and baby is not breathing, that means apnea. So this is what is known as non-vigorous child. The heart rate is less than 100 and the baby is apneic. In that case, go for positive pressure ventilation. This might be given by bag and mask ventilation, which is a non-invasive procedure, or we can go for invasive one just by putting an endotracheal tube. So even after doing positive pressure ventilation, if you see that the heart rate is still dropping, like it is below 60, that is a telltale sign of starting chest compressions. So you have just 30 seconds to make a decision of chest compressions after giving positive pressure ventilation. Chest compression के बाद you assess the heart rate whether it is increasing or not. If this is not increasing, in that case we can give a sort of injection epinephrine in 1:10,000 dilution in the umbilical vein or in the interosseous route. The dose is 0.2 ml per kg or 0.02 mg per kg. We can also put the adrenaline injection via endotracheal route, but the dose will be 1 ml per kg there. So even after giving injection adrenaline, if there is no improvement, then think of volume expansion. Just give 10 ml per kg of a bolus saline. That will be sufficient to gain the volume, and usually done as a last effort where definitive history of blood loss like antepartum hemorrhage etc. are present. So this is the algorithm that you have to follow in neonatal resuscitation. Maximum duration of neonatal resuscitation is 20 minutes only. Even after that, if there is no improvement in the vitals, then call of resuscitation and declare the child as dead. The timeline between the initial step to positive pressure ventilation is just 1 minute, and that is known as golden minute of resuscitation. Okay, that's why start resuscitation immediately, and the timeline between positive pressure ventilation to chest compression I mentioned it is 30 seconds. Okay. Now few points regarding bag and mask ventilation. Number 1, what is the volume of bag used for the resuscitation in bag and mask ventilation, that is around 240 to 750 ml. So we start bag and mask ventilation when the heart rate is less than 100, and the response that we are looking for is increase in heart rate, that is more than 100 per minute. Now suppose you put the baby on bag and mask ventilation and there is no response. What will be the next step? Suppose in this case heart rate is less than 100 only, but obviously it is more than 60. There is no requirement chest compression. So in this case, should we start chest compression? So remember, in this case, when you put the patient, we put the baby on bag and mask ventilation and there is no response and heart rate is not below 60, so you need to go for ventilation corrective steps, and that can be remembered by MR SOPA. M for mask readjustment. Look for the size of the mask, whether it is larger than the baby's mouth. Reposition the head. R for reposition the head. S for suctioning done. O for opening the mouth and look for any obstruction that are present. P for pressure to be increased, and A for altered airway. That means you need to establish endotracheal tube if it is not responsive to bag and mask ventilation. So if mask readjustment or repositioning head, these are first tried, and if not, then we go for endotracheal intubation. Even after that it is not, then we have to go for chest compressions. Okay, next question regarding bag and mask ventilation is, what is the recommended oxygen that is given? It is 21% oxygen, that is room air only. Number 3, what is the rate of bag and mask ventilation? It is 40 to 60 per minute. And what is the pressure that is generated in the first breath? That is 30 to 40 centimeter of water. In the successive breaths, this is half, like 15 to 20 centimeter of water. Okay, repeating all 4 questions regarding bag and mask ventilation. Number 1, the volume of bag 240 to 750 ml, the rate of ventilation 40 to 60 per minute, the pressure that is generated 30 to 40 centimeter of water, and recommended FiO2 is 21%. If it is a preterm baby, in that case we need to increase it to 30% of oxygen also. But always there is a concern of retinopathy of prematurity. So always never give 100% oxygen or a higher concentration oxygen to these babies. And assess the SpO2 in 1 minute, 2 minute, 3 minute. Remember, 70 to 75% oxygen saturation should be present at 3 minutes. Okay. So few questions regarding chest compressions in neonatal resuscitation. We follow 2 thumb technique. The site where we give pressure is lower 1/3 of the sternum above the xiphisternum. Okay, and the depth that we compress in the chest compression, that is 1/3 of the AP diameter. The rate at which we give chest compression and ventilation is 3:1. So in 1 minute you provide 90 compressions and 30 ventilations. Okay, and for the ventilation it is usually given by alternate airway like endotracheal tube. Okay, if it is possible, that will be good. So this is all you need to know regarding neonatal sepsis. Now before ending this session, my question for you will be, what is the absolute contraindication for bag and mask ventilation? If you know the answer, put it in the comment section. Thank you.